Welcome to you all, to you in this room and to you taking part via the live webcast. As a beloved late CBC radio broadcaster used to say, all you out there in vacuum land, which today I guess we would call e-vacuum land or otherwise known as cyberspace, you're all taking part today. I'm Gordon Hardacre, a family doctor at the Toronto Western Hospital and the University of Toronto. Firstly, I would like to express our thanks to the Parkinson Society of Canada and to its organizers for today, Mr. Chris Ron Kane, who's the Executive Director for Central and Northern Ontario, and all the people in the CNOR branch of PSC who put this together, and Barbara Snellgrove, National Director of Education, Sarah Ruji, and to those people who will help with handling your questions later, especially Sandy Jones and Jan Duff, many of whom you may know. Also, a very special appreciation to Novartis for its generous financial support of this educational event. We shall hear our distinguished speaker for approximately 1 hour, followed by a generous time allowance for those questions. Questions from you, the audience, and from those watching the webcast via their own online instructions on the internet, and boy, they're flowing in already. Like many of you, I have Parkinson's, with its own circumstances and complications, which means it's going to be a very exciting afternoon until about 4 p.m. for us because of our excellent speaker and because of his most important topic. Without prejudicing his talk, I'm sure, as you know, Parkinson's disease can have not only a vast array of muscular or motor features, but commonly a variable number of non-motor or autonomic nervous system features, psychologic features, and non-autonomic features too, as may also the disease's drug treatments have their own motor, autonomic, psychologic, or non-autonomic side effects. These features of disease and or of treatment can confound us and make life difficult. Our speaker, Dr. Mandar Jog, is founder and director of the Movement Disorders Program at the London, Ontario Health Sciences Centre and Associate Professor of Neurological Sciences at the University of Western Ontario, with several cross appointments to other departments. I sincerely welcome you, Dr. Jog, to Toronto. Dr. Jog is an advisor to the Parkinson Post. He teaches and consults far and wide, and today will address that large non-motor realm of Parkinson's. He's a 1988 medical graduate of Memorial University in that most charming city of St. John's, Newfoundland. My wife and I fell in love with that city and province last year and will return next summer. He was a resident at McMaster and then a Neurology and Movement Disorders Fellow under the renowned Dr. Anthony Lang here in Toronto at the Western. Thereafter, Dr. Jog spent several years with Dr. Anne Graybeal at MIT in Boston, working in the mathematical areas of her fields of study, which are very interesting and especially interesting to me. That is the basal ganglia brain circuits and dopamine metabolism, especially as they relate to cognition and non-motor behaviors. His other interests include the development of microelectrodes to both record and stimulate activity, right down to the individual neuron or cellular unit. Dr. Jog has many grateful patients and trainees, not only in Canada, but also in Mumbai or Bombay, India, where he teaches from time to time as he goes back each year to Seth Medical College as assistant professor and sees patients at the Lee Lavati Hospital. He is international honorary president of the India Society for Movement Disorders. A senior medical student from the University of Western Ontario clerked an elective with me in the autumn of last year and joined one of Dr. Jog's colleagues in India. You know that we all need to work at breeding movement disorder neurologists for the future. They're in great need indeed. Without further ado, I give to you Dr. Mandar Jog.
Thank you very much. Well, thank you very much for having me. I guess the microphone is right on here. So thank you very much for having me do this. This is an interesting experience for me as well. I've done 1 or 2 webcasts before, and it's always strange to get questions from anonymous people that you actually are not able to see and answer those questions. Body language has a lot of meaning, and the webcast kind of takes that away to a certain extent. So it's good that we have some live audience participation here as well, as compared to talking to simply a camera. The topic that I've been asked to speak on is a difficult one, and yet an extremely important one. And indeed, I should say that it's only really over the last 4 or 5 years that we've come to realize the importance of what we call non-motor symptoms of Parkinson's disease. And in fact, when James Parkinson first described Parkinson's disease in 1817, there's controversial reports as to whether he was able to observe any, if at all, most important aspects of this component of Parkinson's disease, which is a non-motor symptom, such as depression and dementia. In fact, in his monograph, he had written that intelligence is actually preserved in patients with Parkinson's disease. But that's something we know very well these days is one of the most important things that's affected in Parkinson's disease. Similarly, he was not able to observe advanced Parkinson's disease symptoms such as wearing off of Parkinson's disease medications because there was no such thing available. So given the fact that Parkinson's disease was described in the Western world by James Parkinson in 1817, really the newer aspects of Parkinson's disease have become much more important to the treatment of our Parkinson's patients with the advent of medications, with the advent of allowing treatment for a period of time where patients are now able to function for 10, 15, 20 years with this disease, and then develop a lot of the other symptoms that in the James Parkinson's day would not have been visible to him. In fact, James Parkinson probably didn't actually diagnose these patients in a clinical setting. Some people feel that he observed them as a third-party observer rather than a treating physician. So I'm going to learn how to do this. I simply have to press this button. And magic. There we go. So I'm going to talk about two aspects of advanced Parkinson's disease. The first part is not the traditional non-motor part, but is included in the larger capsule of what we call wearing off. Why am I talking about wearing off? Well, it's important because many of the symptoms, which are non-motor symptoms, such as even pain or sweating, can come about during the time the patient is wearing off. Okay? It may not actually be the only time where you have these symptoms, but you need to understand a little bit about this sort of wearing off phenomena and what it is to be able to recognize that these symptoms that we're going to talk about in a little more detail later on can occur predominantly here. Now, there is no traditional definition of wearing off, and I've got 2 or 3 people that have talked about what wearing off might be. And I've got a definition from one of the experts in Canada, Ali Rajput, who says that it's a predictable decline in motor function. Okay? I highlighted this specifically for that reason. This is Ali Rajput, who's world-renowned, one of the best movement disorder neurologists, and I respect him tremendously. Yet, we described in the year 2000, all of us, wearing off as being a predictable decline in motor function at the end of dose in a patient with previously stable response receiving 3 or more doses of levodopa. But I just said 2 minutes ago that wearing off can actually predominantly be, often be, also a non-motor phenomenon. So right here, the first definition of wearing off itself has to be modified to say a decline in function. And we'll talk about what that function might be later on. The Parkinson Study Group, again, 2000, a perception of loss of mobility or dexterity, usually taking place gradually over minutes and bearing close resemblance, timing, etc. Here again, you have dexterity, mobility, motor function. Definition that's used in clinical studies, but we don't talk about a non-motor phenomenon. The 2004 validation survey, experiencing greater than 1 of 32 symptoms during a normal day, which improved following a dose of anti-Parkinson medication. You can see that between 2000 and 2004, not much time has elapsed, but we've removed the motor aspects, the importance of the fact that many other things can present as a wearing off out of that definition. What that tells you is that we've gone from mobility and motor function, which is basically 1, to greater than or equal to 1 of 32 symptoms. So here you see that the breadth of Parkinson's disease has gone from what we've understood as tremor, stiffness, rigidity, etc., to a vast array of at least 32 other symptoms. And you say, wait a minute, I thought I understood Parkinson's disease. I thought that it was stiff, slow, shuffling, speaking problems, and postural instability, and that was Parkinson's disease. And actually, that's not the case. Parkinson's is a very large array of symptoms, many of them unrecognized or under-recognized. And really, within this kind of a 4-year framework of time, we're beginning to understand this symptom complex much, much more. Okay. So, definition of wearing off, a complication of long-term dopaminergic therapy where therapeutic benefit of each dose lasts for progressively shorter periods of time and the patient begins to experience a return of their symptoms, okay, before the next dose of medication is due. And we'll talk about some of these symptoms, especially focusing on the non-motor aspects of things, okay? The need for more doses per day is another indicator of wearing off. What we're also going to talk about is the fact that many, if not all, of these non-motor symptoms, as they become important, become gradually unresponsive to medication. So that's the second point that I'm going to make here. Out of the motor dexterity part, we've already replaced it with multiple symptoms, greater than 32, maybe many more. Now we're also going to reduce the medical response aspect of it and remove that from this definition and tell you that many of these symptoms are not only under-recognized, as we talked about, but also are unresponsive to medication. Well, what is Parkinson's disease then? I thought that Parkinson's disease was stiffness, slowness that responded to medication. Now, Parkinson's definition has become much broader because patients are not aware of a lot of these motor symptoms, non-motor symptoms. And not only that, the physicians that are treating are also unaware often of many of these non-motor symptoms. And hence, when you talk about wearing off in response, we only ask and are only told about those symptoms that are motor and those symptoms that respond to treatment from medication. Yet the breadth of Parkinson's symptoms is much wider than that. So it is important that physicians treating Parkinson's disease be aware of many different symptoms of wearing off and specifically ask about occurrence of such changes. Now, this is simply in the context of wearing off. Can you imagine the breadth of symptoms that are out there outside the context of wearing off? I just tried to include them in the context of wearing off because it's an important point. Most of the time, people tell you about these wearing offs. And even in that context, we don't hear much about non-motor symptoms, let alone outside the context of wearing off of medication. Okay? So this myth about Parkinson's being a motor problem with response to medication affecting the motor system is a very small, narrow view of Parkinson's disease. There's a much broader window, much broader scope of symptoms, medications, response, or lack thereof in this complicated disease that we call Parkinson's disease. Okay? So simply, this is a very simple graph which shows you what happens to wearing off over time, and we're not going to talk about wearing off, but since I've mentioned the definition, I thought I'd pictorially show you this. Okay? So the first graph shows in early Parkinson's disease, you get a response to medication. Dyskinesia, which is just one of the problems that can occur in Parkinson's disease, is high up above in the threshold, so you get a good response as a clinical effect, and that gradually changes over time, so that by the time you get what we're going to be talking about, which is moderate to advanced Parkinson's disease, the threshold cycles very rapidly. And that's rapid cycling up and down of medication and drug response produces this fluctuation of symptom complex. We removed the motor aspect, simply fluctuation of symptom complex. May or may not have anything to do with medication. Okay, so what does wearing off look like? Well, there are non-motor symptoms which we're going to focus, but also we got to cover the fact there are some motor symptoms here as well. So I'm going to concentrate on the symptoms that we're going to talk about here. We cannot talk about all of them, obviously, but sensory symptoms. In fact, just as of, last week, I had a patient that was being treated by a very good neurologist in the community in Toronto who came to see us in London and said that I saw this physician, et cetera, and I was very clearly told that my pain cannot be Parkinson's disease. Parkinson's disease is a painless condition, okay? And I'm telling her Parkinson's disease is a painful condition. So wait a minute, this person trained in Toronto, is practicing in Toronto, well-known neurologist in Toronto, et cetera. How come I'm told this? I've heard this from many other physicians. In fact, I would say I would be guilty of the same thing probably 10 years ago when, even when I was training, pain was not something that we commonly were taught. And as Jan will tell you, we train in the same patient population. It's not something we commonly ask patients. Yet, my teacher, Tony Lang, has himself described pain as being one of the more common presentations, and yet, having trained under him, I still didn't ask that question until I became aware of the fact that pain is a very important symptom of Parkinson's disease. Tingling, loss of sensation, restlessness, fatigue. We'll talk about some of these things, okay? Anxiety, paranoia, hallucinations, depression, panic, and cognitive changes are some of the symptoms. I have not yet shown you anything about the tremor, the stiffness, the rigidity, any of the things that we traditionally recognize as Parkinson's disease are not even on the list. Yet these are actually very common. 40% present with pain. 20 to 30% have tingling, loss of sensation. Restlessness, 25 to 30%. Fatigue, about 50 to 75%. Anxiety, paranoia, 30%. Depression, 40%. Cognitive changes, 50%. Okay? These are symptoms that are almost, if not more common than some of the motor symptoms of Parkinson's disease that you see. Okay? Yet it's not uncommon for us to not recognize these things. Okay. As was mentioned by Dr. Hardacre, autonomic symptoms are extremely common in Parkinson's disease as well. The autonomic system, and we'll talk a little more detail about each of these, some of these symptoms anyway, as time goes on. The autonomic system is an automatic nervous system. Okay? So things like breathing, heart rate, blood pressure, etc. These are things that we don't actually have control over. In fact, one of my friends told me very clearly, pediatrician, that even if your child holds their breath, it is exceedingly uncommon. In fact, and chances are zero that the child will stop breathing and die. It's not possible for us voluntarily to stop our breathing to the point of dying. The autonomic or automatic nervous system kicks in, and you've got to breathe. The child is breath holding that children do. You get worried because the child is turning blue, so to say. But it's not going to result in death because the autonomic or automatic nervous system kicks in. So the automatic nervous system manages many of these things. Abdominal movement of food, right? We don't control it. Urinary problems or urinary system, pupils, saliva, salivation, swallowing, etc. A lot of these things are managed along with the blood pressure, etc., in an automatic way. Yet at the same time, the autonomic nervous system is one of the earliest systems to get affected in Parkinson's disease. And certainly later on in Parkinson's disease, it is very common to have these things occur. So abdominal bloating, urinary frequency, fast heart rate, sweating, flushing, blood pressure changes, all of these things can occur as symptoms of Parkinson's disease. So far, I've named at least 30 different things. Not one of them is dexterity, motor problems, shuffling. You say, wait a minute, I thought you were talking about Parkinson's disease. Well, this is all Parkinson's disease, right? And it's interesting, as I said right at the start, how between the year 2000, where our definitions were predominantly still, and they still are in clinical practice, related to motor symptoms, have changed to include a lot, if not all of these things. In fact, when I present these kinds of slides up on the screen, it's not uncommon for patients. We just did a spring conference. There were 325 people in London that attended our spring conference. People are coming up and saying, wow, I have all of those symptoms. How come nobody ever asked me about these symptoms? It's because we don't recognize that these are symptoms of Parkinson's disease. They're all there. Okay, we won't get a chance to talk about all of them, but we'll talk about some of them. So I gave you sort of a blanket overview of wearing off. In the context of wearing off, all of these symptoms, which are so-called non-motor symptoms, can occur. Certainly the motor symptoms can occur. Okay? Out of the context of wearing off, many of those symptoms can continue, can occur independent of medication. In fact, most, if not all, of those symptoms that I've put up there are generally not responsive to typical Parkinson's medications. Some of them are if they occur during a wearing off period. So I have patients who get restless, anxious as a wearing off phenomena, and if I treat them with traditional dopaminergic medication and adjust their dopaminergic treatment just like I've been taught and by my patients most of the time as to how to adjust their medications, their wearing off phenomena, even if it is a psychiatric wearing off symptom, will improve. But then there are many other times where these symptoms are unrelated to medication and have to be treated independently. So I just put up this first slide just as a introductory slide of challenges of advancing Parkinson's disease. Okay? Advancing Parkinson's disease doesn't mean advanced Parkinson's disease, because you can actually have patients who have many of these symptoms early on. Okay? So I wouldn't say that many, if not all, of these symptoms only occur after year 17 of Parkinson's disease. That's not true. They can actually occur very early in Parkinson's disease. But in patients who are advancing with Parkinson's disease, you can see that the support required, okay, stage 3, 23 tasks per day are done by the caregiver. Okay? This is one of the other non-motor symptoms of Parkinson's disease. Okay? The amount of care burden that is required to be given the patient. Now, this is something that we ignore. It is an important non-motor symptom, isn't it? Because it's not simply that the symptom has to be managed. It is who manages the symptom. Okay? And it's true that caregivers are often spouses that are looking after these patients. But you've got to remember that caregiver burnout is very high in Parkinson's disease. By stage 4 of Parkinson's disease, which still is not bedbound, but patients are ambulatory but not well, greater than 30 tasks per day are done by the caregiver. This is a huge non-motor symptom of Parkinson's disease. Okay? I also put up something, just one liner about exercise, that most patients can do this. Okay? It is not necessary for you to be sedentary when you've got Parkinson's disease. But remember that exercise, in case of Parkinson's disease, is something that has to be done slowly, in short bursts, rather than 45 minutes on a treadmill. Okay? That's not something that is a good thing for a Parkinson's patient to do in the later stages, because fatigue is a very, very important problem with Parkinson's disease, and tiring yourself out is not a good thing. Yet, not exercising is also not a good thing. So exercise is an important aspect of it, and I think the Parkinson's population knows this, the physicians don't tend to know this very well and are not sure as to what to recommend. Yet, there are many, many different types of exercise regimens available for Parkinson's disease. There is no standardized method of doing exercise in Parkinson's disease. Nutrition. Weight loss is a very important symptom of Parkinson's disease. We're told about patients on a regular basis, yet patients are not told by us that weight loss is an important symptom of Parkinson's disease. 4 times more likely to lose 10 to 15 pounds. Okay. Now, obesity is also seen, but it's much more common for weight loss to occur. 20 pounds within the first 2 years of weight loss with Parkinson's disease is not an uncommon thing. Okay. Many reasons why. In fact, on Friday, we had a medical resident who was doing a rotation with us for that day and came in. The first thing that she said was that, wow, it's amazing. This person is 55 years of age and has no teeth, Parkinson's disease. That's not something that's common, is it? So, well, actually, what do you know about dentition in Parkinson's disease? And the dentition in Parkinson's disease is actually very poor. One of the main reasons for that, well, actually there are many reasons, one of the main reasons for that is that spontaneity of movement is reduced in Parkinson's disease, as you know. This facial akinesia. Similarly, tongue movements or spontaneous tongue movements are reduced in patients with Parkinson's disease. Okay? So one of the things that I would do normally if I've just had, lunch or dinner, I clean my teeth with my tongue. All of us do that, right? Or I'm on web camera doing it. But Parkinson's patients tend to not do that. Now, we don't actually have a way of putting a camera in somebody's mouth and watching their tongue movements, but it's not uncommon to actually ask patients this, and they'll tell you that. But one other sign of this is drooling. Right? Most of the time, when we have saliva in our mouth, you generate a bolus with your tongue movement. You can't move your pharynx or the rest of the mouth very well, but the tongue pushes the saliva regularly to the back, and we swallow it. Swallowing mechanism is impaired in Parkinson's disease, but so is tongue movement. So clearing of food particles from the teeth is very poor in patients with Parkinson's disease. On top of that, the medications that we use often cycle between dryness and hypersalivation. Okay? So dryness, hypersalivation, drooling at the same time, dryness of mouth. So this contrast is also an important component that causes bugs and other things to grow in the mouth. And finally, of course, bradykinesia, not brushing your teeth fully, getting the brush in, and amongst other reasons. So dentition is actually very important. But it also indicates that there is swallowing impairment, which we may get a chance to talk about. The third thing I wanted to say about nutrition, because there's nothing to do with necessarily advanced Parkinson's disease, but it has an impact on response to medication. Protein interaction. Okay? This is something that I've gotten into telling people right at the start. It's not something that actually impairs patients at the beginning, but as you advance with Parkinson's disease, even subtle things, such as interaction with protein and levodopa, is an important component of why patients might be wearing off, because proteins interfere with levodopa. Levodopa is actually a protein, dihydroxyphenylalanine. So if you take a certain type of protein along with levodopa, it's not going to get absorbed. Okay? So you got to be careful and wait probably for about an hour after you've taken your medication to take your meal. Okay? And if you've eaten a big meal, which has protein in it, you got to wait about 2 hours for that protein to be absorbed before you take the dose of levodopa. Otherwise, you're not going to get much absorption. Even at the best of times, only about 7 to 8% of the levodopa actually gets absorbed into the brain from what you've taken. So if you take 100 milligrams, about 7, 8 milligrams gets into the brain. Okay? So if you have interaction on top of that, you're going to get even less amount of levodopa entering the brain. This is even with the carbidopa on board, by the way. In fact, my friend Ali Rajput will tell you that when they first started using levodopa, early in the 60s, I wasn't really around then, but at that time, the amount of levodopa that was being used was 15 grams, 17 grams. And even with that, you were only getting a small amount of benefit. In fact, when it was first used in Europe, and not abandoned, but not particularly pushed forward until Dr. Kotzias started using levodopa in chronic treatment, the amount of levodopa that was being used in Europe was so low that even though there was a transient response and benefit, it didn't last, and therefore it was never adopted until Dr. Kotzias used the long-term chronic treatment with levodopa. So nutrition, exercise, support, important things with respect to the treatment of Parkinson's disease in advancing stages. So now let's get into some of the symptoms that are an important sort of non-motor block of Parkinson's disease symptoms. Okay? We'll start with constipation. Constipation is an intrinsic autonomic problem in Parkinson's disease, and we know now very well that constipation may predate onset of Parkinson's disease by many, many years. In fact, I'll show you a little bit of data from a recent study that came out that tells you that it's possible that autonomic dysfunction such as constipation could be an indicator of Parkinson's disease onset, even 10 years before motor symptoms of Parkinson's disease. Why is this important? Because at this point in time, pathologically, if you look at development of Parkinson's disease, people feel that it may even begin in the autonomic nervous system in the bowel, and constipation may be an early presenting symptom, let alone a problem that presents later on in treatment of Parkinson's disease and becomes a huge problem. In fact, I think probably 70 to 90% of our Parkinson's patients have substantial constipation. It's a difficult problem to manage. And we use things such as stool softeners, stool bulk laxatives, and mobility or motility agents. So when you're treating constipation, you've got to have stool there. You've got to have something that is enough size. You've got to have not only bulk, but you've got to have soft stool there, something that will move. And then on top of that, you've got to have something that will move the stool, okay? Because the autonomic nervous system works by bulk. When the bowel stretches with the size of the stool, there's a signal sent to the brain saying, move the food or move the stool, whatever's there, all the way so that it can be evacuated. If the stool is small and hard and dry, that signal is not sent. If there's an autonomic problem on top of that, which means that the signal from the bowel is not getting to the brain properly, and it's slowed down like everything else in Parkinson's disease, it's not going to move the stool fast enough. Okay? So you need bulk laxatives, you need something to move the stools, you need something that gives it size, all of these things. So I use things such as softener because you have soft stool. We use laxatives that allow water to be absorbed, and then we give motility agents that help move the stool. You may have to use one or another or a combination of all of these things to get bowels to move. Of course, using high brand foods, et cetera, are important. Okay, so constipation, and that's the slide I was talking about, age-adjusted incidence of Parkinson's disease according to bowel movement frequency. Who would have thought that we'd be looking at bowel and that movement disorder as compared to Parkinson's disease, which is a mobility disorder? So in a way, I guess, movement disorders includes all things, including constipation and bowel. So we're actually gastroenterologists in disguise, so to say. So if you look at the frequency of bowel movement, this is a very large study. It has nothing to do with Parkinson's disease, but it was a large population-based study that people looked at. Less than one bowel movement a day, 18.9 rate per 10,000 person years. One bowel movement, 7.9, 5.4 with two bowel movements a day. This is age-adjusted incidence of Parkinson's disease according to bowel movement frequency in midlife. It has nothing to do with patients diagnosed with Parkinson's disease who are having bowel movements less than one or two. These are people who didn't have Parkinson's disease when these symptoms were recorded, but then followed over a period of time how many developed. And those that had less than one bowel movement, and this goes along with the current understanding of pathology